Voilà, c'était ça qu'il fallait jouer. C'est ce petit bouton.
Ah, quel art.
Oui, oui.
Okay, let's start now. Hello and welcome everyone. My name is Tarek and I'm part of the international sales department at Easy Search Medical. It is our great pleasure to welcome you to the 6th episode of our bariatric webinar series. As you maybe know, this series will have 10 episodes, which means we are like halfway through, and till now it was a great success. The first thing I'd like to do is to introduce today's speakers and the moderator. So we have Professor Antonio Torres from Spain, who will be the moderator for today. It's a great pleasure to have you again here, Professor Antonio Torres. Then we have Professor Yuri Kontratsky from Ukraine. We have Dr. Richard Habitan from Morocco, Professor Tamer Nabil from Egypt, and last but not least, Professor Stenko Buras from Croatia. I would like to thank you all for your contribution in today's episode. It is really a great pleasure to have you as such an international group of surgeons with us here today. You are the main reason for the success of this event, and you are the reason why so many people all over the globe are following this series. And if I say like all over the globe, I mean it. Because if I look at the statistics of the previous events, it becomes clear that people all over the world are watching us. And the reason why we came together is we all have the same desire. We want to learn and we want to educate ourselves in the bariatric field. Therefore, I would also like to thank everyone who will join us today. We are pleased to welcome those of you who have been with us in the last 5 episodes, as well as those of you who are new to this event. And now I wish you a great event and, more important, a very educative session. And I would like to give the word to the moderator of this session, Professor Antonio Torres.
Hello, guys. Hello, dear friends, dear colleagues. I think the first thing I'd like to do is to thank, Series-6th Medical Company, for its outstanding commitment with training and teaching doctors and to educate patients in many topics, but especially in this bariatric surgery topic. I think today's meeting is very important because I think, the relationship between obesity and cancer is already well established, and it's going to be one of the most important targets we will deal with it in the near future. But in the present time, there are, as all the speakers will tell us, important relationship between obesity and the incidence of different types of cancer. So today we are very lucky because we have here an outstanding panel of speakers, and I think for the sake of time and taking advantage of the different lecture, I would like to start the meeting. The way we will deal with this subject gonna be, we are to hear the presenter, the speaker, and then we will have some discussion, time discussion, including our panelists and other people that can join us regarding answering or putting up some questions. So our first speaker is Dr. Yuri Kondratsky, already introduced by Tarek, and he is the head of the Department of Upper GI Tumor at the National Cancer Institute in Ukraine. I think he's a very important leader regarding this topic, and their approach going to be to talk us about if are bariatric surgery useful for prevent cancer. So Professor Kondransky, your turn. The podium is yours. If you want, you can share your screen, and we will looking forward to hearing your words. Go ahead.
Okay, thank you. Thank you, everybody. Hello. I'm glad to meet this little conference, and usually I don't care about bariatric, but I usually my normal work is with cancer patients, but now it's obesity is one of the important side of prevent cancer, and represent my presentation bariatric surgery useful to prevent cancer. Where I'm from, Ukrainian, it's one of biggest European country, and the population is 40 million people, and we have big hospital who specialized on oncology. It's National Cancer Institute of Kiev. Yeah, we usually was founded in 1920, and we work with different cancers. And my department is upper GI tumors department, more than 2,000 patients per year and more than 600 operations about upper GI tumors. And 20 years ago, we usually, when we see oncology patients, usually we know what about it, and left patients, it's usually esophagus cancer, and right patients, it's usually proctology or colon cancer. But now everything is changes, and you see my employee, it's my doctor in middle, and left and right, it's patients with esophageal cancer who have obese, and left is before operation, right at patients who have the operations yet. But we see obesity is real problem even, and esophageal cancer. Of course, it's a global problem because about statistics, 20%, approximately 20% is obesity is accounted with cancer cases like esophageal, thyroid, colon, renal, liver, and others. And it's common problem because a major review of weight, physical activity, and cancer incidence in International Agency of Research of Cancer used obesity prevalence data for Europe and relative risk in meta-analysis published study, and concluded 11% of colon cancer, 9% of breast cancer, 39% endometrial cancer cases, 25% kidney cancer, and 37% esophageal cancer. In USA, it's same problem. In 2014, approximately 600,000 persons in the United States received a diagnosis of cancer associated with overweight or obesity, representing 40% of all cancer diagnoses. How may obesity increase the risk cancer? We have some mechanism, but not only one. It's maybe more than 20, I think. But today we decided that obese people often have chronic low-level inflammation, and it's over time in case DNA damage and leads to cancer. Of course, for example, chronic local inflammation included both gastroesophageal reflux disease or Barrett esophagus is like a cause of esophageal adenocarcinoma. Another main problem is obese people often have increased blood levels of insulin and insulin-like growth factor 1, high levels of insulin of EGFA1 may provide the development of colon, kidney, prostate, and endometrial cancer. Of course, it's not all lists, but we understand that we have many mechanisms to provide cancer. Another problem, it's significant positive about death with patients with cancer and obesity, the relative risk of cancer. Significant trends of increased death rates with increase in body mass index are summarized for the highest categories, body mass index men, and we have same picture in women. Yeah, it's really higher risk of death in this cohort people. Of course, one is interesting investigate its high BMI as associated with cancer of esophageal and esophagogastric junction adenocarcinomas. The association of esophageal and esophagogastric junction adenocarcinomas increased directly with increasing BMI. Compared with individuals with BMI lower than 25, and another group as BMI was more than 40, it's associated with both esophageal and esophagogastric junction adenocarcinomas. Between BMI and gastroesophageal rectal symptoms in relation of esophageal and esophagogastrial junction adenocarcinoma risks. In another investigation, as we look like bariatric treatment for cancer or prevent the cancer risks, yeah, perhaps the best evidence of this weight loss can reduce the risk of cancer comes from recent studies of bariatric surgery patients. Emerging evidence from two large cohort studies suggests that large weight loss from bariatric surgery reduces the risk of cancer death. The mean weight loss was in the range of 14% to 27% 15 years after surgery in the Swedish patient population. Similarly, the USA-based study found a significant cancer risk reduction in bariatric surgery patients. That study found this risk reduction was largely concentrated in obesity-related cancers. Both studies demonstrated a lower cancer incidence in surgical patients. The Swedish study demonstrated a lower risk for cancer in women undergoing bariatric surgery than matched obese controls, so no such effect was observed in a man. And very interesting investigate its association between weight loss and the risk of cancer after bariatric surgery. The final matched cohort had 18,000 bariatric surgery patients and 40,000 non-surgical matched patients. Over 80% were female with an average age of 46 years. The two groups were well balanced on the both of presence of obesity-associated conditions and risk factors for the development of cancer. Overall, the average one-year weight loss was 27% among patients undergoing bariatric surgery, versus 1% is matched non-surgical patients. But it's interesting because investigations build the models. It's in Cox proportional hazard models that included both surgery status and percent weight loss as predictors of cancer incidence. Estimated percent weight loss at 1 year was significantly associated with reduced risk of any cancer in the unadjusted model. While bariatric surgery was not a significant independent predictor in unadjusted or adjusted models. Same situation in investigating the effect of weight loss separately in those who underwent bariatric surgery and those who did not. In patients who had bariatric surgery, estimated percent weight loss at 1 year was significantly associated with a reduced risk of any type of cancer. But we have very interesting conclusion in theoretical conclusion, and for patients having bariatric surgery, for each 10% weight loss, there was 14 reduction in cancer risk. Thus, for the average bariatric patients who loses 27% of their weight at 1 year, the reduction in cancer risk is 34% using the adjusted results, 46 with the unadjusted results. Among obesity matches who did not undergo bariatric surgery, estimated weight loss was small, 1% at 1 year, and was not associated with change in cancer risk. But very interesting result, and authors did conclusion that we did not find statistically significant evidence in this study that the reduction of obesity-associated cancers among bariatric surgery patients was associated with the weight loss. It's not, it's very interesting because we have another opinion on this time. And does obesity increase the risk of cancer? No choice, yes. But are bariatric surgery useful to prevent cancer? Not sure. I think we will do some new investigation to investigate this problem. In conclusion, we may do conclusion should base it on our results, historical and continuing increases in the global prevalence of high BMI, especially in younger cohorts, are expected to translate into further increases in cancer burden in the future. The large burden and cancer attributable of high BMI points to the importance of a weight control program. We still have existing gaps in our knowledge about the association between BMI and cancer. It also emphasizes the need for research into effective interventions to control weight gain to avoid further increases in the burden of cancer related to high BMI. Thank you for your attention.
Thank you very much, Dr. Kondransky. Absolutely outstanding lecture. Can you stop sharing your... okay, very good. Here we are. Okay. Well, I think, you pointed out the most important factor involved, in the relationship between cancer and obesity. Very interesting data. I have some question, but the most important question is though related with your message about the study that we know for Filshauer and Attenborough, saying that even in their study, they didn't find a correlation between weight loss and the decrease of cancer in patients operating on bariatric surgery. Very important. It remind me, that probably there are other mechanisms apart from the weight loss involved in this cancer prevention issue regarding with bariatric surgery. What do you think are the other mechanisms involved in this positive effect of the bariatric surgery over patients suffering from cancer apart from the weight loss? What other mechanisms do you think are important in getting this effect?
To prevent cancer, or to treat cancer patients after bariatry?
No, to reduce the incidence of cancer in operated patients. Which is the mechanism? What the mechanism do you think apart from the weight loss? Because it's clear that as higher weight loss in the other study, a higher weight loss you get, more protective effect you have, right? So apart from the weight loss, do you think other mechanism? I am thinking in the anti-inflammatory effects of the bariatric surgery. So in this global anti-inflammatory effect, probably cardiogenogenesis has an important role. What do you think about that?
Yes, its main problem is chronic inflammation in which have the patients with obesity or obese. But in cancer prevent, it's not only because we have many mechanisms. It's growth works bowel, and it's problem with cardiovascular system and oxygenation of organs, and it's complex problem. And in real, we don't we only start to care about this problem in Ukraine because before it we haven't any problem with obesity, and it's only start. We look for new way to prevent the cancer, because before it we only treated. Yeah, but we see the growing the population with obesity.
Do you find in your country, in your experience at your hospital, differences between women and men? I mean, because many studies, including the Swedish obesity study, they found, a more important effect in women compared with men. Do you see this kind of result in your practice there?
Yeah, we see differently. It's the first point that we see that in gynecology department we have very big percent of obesity people, and it starts to find cause why it's happened. And after that, we grow percent of obesity people in colorectal system. When we look around and see this problem in other world, work with it more than 20 years, we only started. But yes, it's we have more women with this problem than men, but it's growing up in men too, but little slowly maybe. It's maybe it's women that faster growing.
Absolutely, because we are now in our country in Spain. We are seeing now, as you said, especially at the gynecology department, the appearance of very unusual cancer that we didn't face on them before. I mean, endometrium cancer. It was very exceptional earlier on, and now we are seeing an increased number of these kind of patients. It's very interesting how, even the relationship between gender, probably, this anti-inflammatory effect or this effect of adipose tissue carcinogenic related with the, with the hormones, sexual hormones. I mean, going to be some relationship, because I agree with your conclusion that we need some more investigation of other mechanisms apart from the weight loss regarding the positive or the beneficial effect of the bariatric surgery. The other speaker, do you have any question? Professor Nabil, Professor Avitan, Professor Boras, any comment, any question to our first speaker? Please raise your hand, and you are absolutely open to comment with him any question. Yes, Professor Avitan, go ahead.
Yes, I think in my experience, I observe more cancer in female obese. So I think there is the relation between obesity and cancer is increasing with the sex. My own experience, I observe more cancer in female obese.
It's very, I agree with you, Professor Vitan, because as you know, breast cancer, colorectal cancer are so huge, the number as huge, going to be very difficult to differentiate. But in this very exceptional, non very frequent cancer like endometrium, some other sarcomas cancer, it's going to be interesting. But anyway, Any other comment, guys? Professor Nabil, Professor Khoury,
No, thank you.
Professor Boras? Yes, Professor Nabil, go ahead.
No, this is going with the literature. What Dr. Apitan said, that his experience that females, the obese female has more cancers. Expected that females are more prone to do bariatric surgery. So when they lose weight, at this time, the incidence of cancers among female will be lower than that among males. That's, I think, goes with the literature exhibited by Dr. Yuri.
Yeah. Okay. So, Professor Bora, you probably will inform us more precisely during your talk. But do you have any comment on this topic that Professor Kondrasky? Go ahead, please.
Yeah, when we talk about this Professor Schauer study, when you look in depth, you can see that in this study, over 80% of the surgical cases were women. And why did they react so fast to cancer reduction? Is because of the sex hormones, probably, right? Because estrogen levels are very highly sensitive for endometrial cancers and postmenopausal breast. And that's why they probably react very fast without losing too much weight in the beginning. So I think that is the main reason, and that is the probably conclusion from the Phil Schauer's work, right?
No, absolutely, absolutely. This study showing us, that there are other mechanisms, involved in this effect apart from the weight loss. Now, the same happened, guys, with the metabolic surgery. All of us, we know that, weight loss is important, but all the incretin effects, GLP-1, PYY, modulin, other factors are involved in metabolic effect. I mean, bile acid, recirculation, gut signaling, there are so many mechanisms. We don't know almost nothing at present time.
Yes, I agree.
Absolutely. Okay. Okay, so there's no more comment. Let's move on to the next speaker. Going to be Professor Richard Avitan. His topic going to be related with the very, I would say, not controversial, but very new approach for our friend David Noka. The Nissen sleeve. The topic he will deal with is why and how I do Nissen sleeve approach. Richard, it's up to you. The podium is yours. Go ahead.
Thank you. I am so happy to be invited in this meeting. I want to share with you a small experience about Nissen sleeve. On y va. On va descendre. Non. Ah, il faut que j'enlève ça, l'écran. Do you see the presentation?
Yeah, we see the presentation.
We began. So the question is the question we ask every time with my big friend David Noka. And this question, I want to share it with you today. I present you my anesthesiologist is Dr. Redwan and my dietitian. We know that gastroesophageal reflux disease is a frequent complication after gastric sleeve. Certainly, we have reflux in obese patients, but since we realize the gastric sleeve, we observe more and more reflux after this surgery. I think between 20 and 40% on average, according to main studies. And the question is, does bariatric surgery improve the GERD, the gastroesophageal reflux disease? It's not true. Gastric sleeve increase significantly chronic reflux. Currently, for the surgical management of morbid obesity with reflux or hiatal hernia, the gastric bypass is the gold standard procedure. So we can tell that gastric sleeve is a contraindication. And you can observe this table is a study, the study of Series-6th. It showed that after gastric sleeve, 5 years after, you had 70% sleeve. 5 years after, you had 70% sleeve. 5 years after, you had 70% sleeve. 5 years after, you had 70% 40%, and after operation, 70%. The study concerned 150 patients. So, what to offer to patients who refuse gastric bypass? What to offer to patients with asymptomatic hiatal hernia? And what to offer to patients where the gastric bypass is really a contraindication? And I give allusion to Crohn's disease. The Montpellier bariatric team, led by my friend David Noka, has recently proposed a hybrid technique, the Nissen sleeve. Our experience has concerned 70 obese patients with hiatal hernia or symptomatic reflux. And I have published this experience in an article in obesity surgery with my friend Guggenheim of the Nice bariatric team. Between 2007 and 2019, I have personally operated 1,800 gastric sleeve and 100 Nissen sleeve. The age mean is 40 years. I have more female than male, and 90% of my patients have hiatal hernia. The mean operative time is 1 hour. The patient discharged after 2 days. And I had 3 complications. One, uncontrolled bleeding, which obliged me to convert in open surgery. Bleeding, spleen bleeding. I have 1 fistula under the valve, and 2 stenoses in relation with twist. Because the technique of Nissen sleeve is not so simple. At 1 year, I have an excess weight loss of 60%. About the reflex, I have a good result because from 70% before surgery, we observe 1% after surgery. Even in the use of the PPI, we go from 80% to 7%. I'm going to show you a video. Comment tu fais pour passer ça? Et tu lances la YouTube. Can you tell me if the quality is good? You see good?
Yeah, we can see, we can see.
Yes, so the beginning of the operation is like a reflex surgery. I dissect the right pillar with the hook because the first time of the operation is to treat the hiatal hernia. And I get off the esophagus at 7 centimeters. We put it in the lace. And I am going to close with 2 or 3 stitches, the 2 pillars, non-absorbable stitches. That I put them with the bougie in place. I don't take off the bougie, I light her in the stomach. After this, I am going to section the vessels, the small vessels with ultracision or ligature near the spleen. I am going to section the small vessels. And to realize a valve, classical valve at 360 degrees. You have a large window. It is important to dissect a large window behind the esophagus. Here is the valve. I'm going to realize a short valve, not a long valve. And you understand why? Because I want to take off the majority of grilling. This is a problem of the Nissen sleeve, is the grilling, which is staying. This is all the stitches are non-absorbent. I have put here in this case 3 teachers, but the valve is small. And I let the bougie in place to avoid stenosis and aphasia. And after, I am going to cut all the vessels of the large curvature and going to fire and load the staples since 3 centimeters after before the pylorus, and I'm going to get up until the valve without injuring the valve. It is important to avoid a twist. And in the Nissen sleeve, I began to reload the staples 3 centimeters before the pylorus, not 6 centimeters. You observe the valve and the gastric sieve. I put clips when I have bleeding in the staples. I don't do coagulation. I prefer clips. You observe the pillars. And after, to avoid the twist, I do 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 an epiploplasty with non-absorbable stitches. You observe the sleeve, long sleeve. Every time I check with the bougie, because I am afraid of the stenosis. I have 2 stenoses in my experience. Even the bleeding is important to avoid it because hematoma is going to transform in abscess. After, in the end, I do blue test. You can observe the blue test.
À partir du début, non, non. Là, il faut que j'aille à la dernière.
In conclusion, can we tell that Nissen sleeve is a new against reflex and obesity, but certainly we need more follow-up and higher number of patients. I am following these new patients 1 year after my study. I have constated that the reflex 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 has diminished, has decreased, but even the BMI in the excess weight, I was 1 year after at 60% of excess weight, but now I think I observe 50% of excess weight loss. Thank you.
Thank you very much, Professor Avitan, for this nice lecture. Can you please, stop sharing your screen?
One moment, please.
Yeah. Okay, thank you. Perfect. Good. Well, guys, excellent lecture. Dr. Avitan, putting on the table, a very attractive and challenging procedure that Nissen sleeve in treating patients with obesity plus GERD. Any comment from the other speaker? Professor Kondrasky, Professor Nabil? Yes, go ahead, Professor Nabil, go ahead.
Yes, good presentation, Dr. Abitan, but I want to ask you, what about the recurrence rate? If you have another reflux after this procedure, is it gastric bypass will be difficult to undo the Nissen and do it?
No, I have experience in reflux. I have 2 patients I have converted in gastric bypass. It's not difficult. I take off the valve with a large staple, and after I do a classic gastric bypass Roux and Way.
Okay, thank you.
Any other comment, Professor Boras? Any comment on this topic?
Not particularly. I personally don't do an Nissen sleeve, and I was trained by the old school surgeons where you would do gastric bypass or a sleeve, right? And Nissen sleeve is something that probably is promising and worthwhile thinking about it as a method. And I'm sure there are patients that are just measured for that procedure, but I'm still not doing it, so I don't have experience and I don't know.
Okay, I think Dr. Avitan, one of the most, I think at present time, because I was discussing or commenting this issue with David Noka regarding, there is no doubt that probably if you face with a patient who has been performed a Nissen procedure for GERD in the past, and now, is obese, probably it's going to be much more challenging to dismantle the previous Nissen and to do, the bariatric procedure that to perform a Nissen sleeve or a Nissen bypass. I think if the Nissen is already there, it's going to be very important to take into account that you can perform another bariatric procedure without the challenge of dismantling, this Nissen, especially the Nissen, has been there for many, many years. Do you agree with this approach, Dr. Avitan?
Yes, yeah. I think I explained to my patients that the majority of my patients refuse gastric bypass, and they want to try the first step. And if the Nissen sleeve, in my experience, because I do a lot of Nissen, standard Nissen, the valve is living minimally 10 years. Minimally 10 years, the valve. If I have failure in the loss of the weight, I can transform the Nissen sleeve in gastric bypass very easily.
Okay. So another important point that you already underlined is going to be the question that it's not a very easy operation for being performed properly. I mean, the last firing of the procedure are going to be very, you have to be very carefully, perform, the stapler, because you can have some problems there if you don't do the procedure properly. My question is, I agree with you that it's not going to be a very, very easy surgical procedure. You have to learn it. You have to properly perform the procedure if you don't get to have problem afterwards. Do you agree with this approach?
Yes, I agree.
Afterwards. Do you agree with this approach?
Yes, I agree.
Afterwards. Do you agree with this approach?
Yes, I agree.
Afterwards. Do you agree with this approach?
Yes, I agree.
Afterwards. Do you agree with this approach?
Yes, I agree. I agree with you. We remember the first patient we do the first. I had a stenosis because of twist, and I had a lot of difficulties to treat it. We put with the endoscopist endoprothesis because the valve, you must be careful that the valve is going to be in the same direction that the sleeve. Oui. Yes. It is not a simple procedure.
Yeah.
I agree with you.
Especially, regarding the way of the, I would say, a spatial configuration of the procedure for avoiding twisting or for avoiding duplicating the wall, the different layers at the end of the sleeve gastrectomy. So I think it's very important to spread, the approach that is not a very easy procedure. And another important point that already Professor Nabil pointed out earlier is if you already had some problem, not only regarding the new appearance of the girl, or just in the case of the patient regains some weight. What is going to be your approach? There is a different approach if the patient regains or if the patient reappearance the girl of those patients. What do you do in these two different circumstances?
In my experience, the first approach when I have regain of weight, I do a gastro scanner, gastro CT, and I try to explain which is the reason of the regain of the weight. A lot of times, I don't observe a dilatation of the tube. I don't observe dilatation. A lot of times, the patients don't follow the dietitian rules. That I have one patient now, I am following her. She has a dilatation, a distal dilatation of the tube, and I have proposed to her to transform the Nissen sleeve on Nissen gastric bypass. I am not going to take off the valves. I'm going to let the valve and to do the anastomosis Roux-en-Y. But the majority of the patients, when they regain weight, I think it is because they don't follow, they don't change the habits of eating.
Mm-hmm. Now, of course, we have some other option like the SADIS procedure or one anastomosis nodal switch, or we have another option. But anyway, it's going to be a very important procedure to take into account. And in my mind, I think for those surgeons, those teams that they already have patient operated by a Nissen procedure. If the patient is obese, don't think in dismantling the previous Nissen, the wrap, going to be very tough. They have to think about, they have this option of maintaining the valve, maintaining the wrap, and do a Nissen, do a sleeve, or do a Roux-en-Y gastric bypass, or another procedure. I think going to be a very important point of information to take into account.
But Professor Torres, if you have to transform the Nissen sleeve, I suggest to transform in Roux-en-Y, because if you do an omega bypass, you are going to increase the reflex.
No, I don't agree into do one anastomosis gastric bypass. I think in doing one anastomosis duodenal switch, SADIS procedure. I mean,
SADIS, yes.
Yes. It's not one anastomosis. I'm talking about, you mentioned regarding the topic we are dealing with today, regarding the cancer and obesity. This is one reason you mentioned to convert a sleeve or a Nissen sleeve in one anastomosis gastric bypass. It's going to be no advisable because the bile GER over there, it's going to be, not advisable conversion. This is my strategy in those patients. But talking about, the relationship between, GER and the adenocarcinoma of the GI junction, I think, it's going to be a good piece of information to have some study, because I was talking to David Noka, Professor Noka, regarding that, to study from the pH-metric point of view on using the Bilitech, the determination of bile in the remaining stomach, in terms of avoiding this carcinogenic effect of the bile within the stomach. Do you have any comment on this topic?
I agree. Personally, I didn't observe Barrett esophagus, but we have done pH-metry before and after, and we observe that there is net amélioration of the pH-metry is is going is better after the Nissen sleeve. But the problem, I am not a big follower. I can come back to you in 1 year and 2 years, and I am going to check this pH-metry. But now the pH-metry is going better.
Yeah, I think going to be important in the near future to check not only the acid during pH-metry. I'm talking about measuring the bile inside the stomach, with a bilitech, to try to check, to study the bile contents, the biliary content of the within the stomach. In the future, I think we need this investigation. I think it's going to be very important to clarify the carcinogenic role or not carcinogenic role of this procedure. Very interesting. Yeah. Any comment, Professor Boras, Professor Nabil? Or
thank you.
Well, good. So for the sake of time, thank you very much, Professor Avitan. Let's go forward for the next speaker, Professor Tamer Nabil. As Tarek introduced you, a very important surgeon there in Egypt, a very eminent surgeon there. And he is talking to us about the very important challenging issue. It's going to be regarding one of the most prevalent cancer at present time, that is the colorectal cancer. Professor Nabil's topic will be the effect of bariatric surgery on colorectal cancer risk. Professor Nabil, the podium is yours. Go ahead, please.
Thank you, Dr. Torres. What about the effect of the bariatric surgery on the colorectal cancer risk? I am professor of surgery, Bani Suef University, and the consultant of bariatric surgery in Egypt. Now the colorectal cancer accounts for about 10% of all cancer cases and 8.5% of all cancer-related deaths globally. There is a well-established association between the obesity and the increased risk of colorectal cancer, which is stronger for colon than the rectal cancer. It is therefore surprising to me and to the literature that some studies have found an increased risk of colorectal cancer after bariatric surgery. Now, what about the proposed mechanisms explaining the increased risk for colorectal cancer in obese? First, the lack of physical activity. Second, an endocrinal pathway, which is a prolonged hyperinsulinemia attributable to increased adiposity, leads to reduced production of insulin-like growth factor binding proteins. This will lead to increased level of insulin growth factor 1, and this may play a role in the colorectal cancer risk because insulin growth factor 1 receptor is overexpressed in colorectal cancers. We have a contradictory results in the literature about the role of the bariatric surgery and loss of weight regarding the increase or decrease the risk of colorectal cancer. And these are two old Swedish cohort studies showed an increased risk of colorectal cancer after bariatric surgery compared to the expected risk. In both studies, the risk also exceeded that of obese individuals without history of bariatric surgery, and the risk increased over time after surgery. This is also additionally in independent studies have shown hyperproliferation of the rectal mucosal cells 6 months to 3 years after gastric bypass, lending support to findings that are indicating an increased risk of colorectal cancer after bariatric surgery. In a recent study from England, published in the British Journal of Surgery 2018, comparing 8,800 bariatric patients with an equal number of matched controls, they found an increased risk of colorectal cancer after gastric bypass surgery. And in a very recent multi-country Nordic cohort study included adults with a documented obesity diagnosis, the incidence of colorectal cancer in participants with obesity who had and had not undergone bariatric surgery was compared to the incidence in the corresponding background population. And the study suggests that bariatric surgery is associated with an increased risk of colon cancer while the support for an increased risk of rectal cancer was weaker. What about the proposed mechanisms explaining the increased risk for colorectal cancer after bariatric surgery? As mentioned in two studies before, there is a hyperproliferation of the rectal mucosa after gastric bypass, but not after sleeve gastrectomy, indicating that the type of bariatric surgery may play a role. Alteration of the gut microbe. Gastric bypass patients have low microbial diversity, which is associated with an increased colorectal cancer risk. Also, some gut bacteria with pro-oncogenic properties that have been associated with colorectal cancer seem to increase after bariatric surgery. Also, increased exposure to secondary bile acids following bariatric surgery, and the studies have suggested that secondary bile acids may induce oxidative stress and DNA damage. The elevated expression of pro-inflammatory and mycogenic genes and changes in protein metabolism as a result of high protein diets recommended after bariatric surgery may play a role in the increased risk. On the other side, this is a meta-analysis of 4 studies revealed that bariatric surgery was associated with a significantly lower colorectal cancer when compared with obese non-operated individuals, and this is associated with 27% lower colorectal cancer risk. Another English cohort study found no increased the risk of colorectal cancer after bariatric surgery compared to the background population, and this is published in the Cancer Epidemiology in April 2018. However, the obesity surgery population was small with limited follow-up. A USA retrospective cohort study of patients undergoing bariatric surgery between 2005 and 2012 with follow-up through to 2014. The study observed a lower risk for any type of cancer in patients with obesity who sought bariatric surgery compared with matched controlled individuals, and I think Dr. Yuri mentioned that in his presentation. This decreased risk also induced colon cancer. And this is a very recent retrospective population-based multi-center cohort study based on the French electronic health data published in 2020, included 1 million individuals with obesity aged 50 to 75 years, and they are free of colorectal cancer at the baseline. The study showed that patients with obesity shared the same risk of colorectal cancer as the general population. Whereas for patients with obesity who don't undergo bariatric surgery, the risk is 34% above that of general population. And this is recent meta-analysis included 7 articles involved total of 1,200,000 patients. Patients who underwent bariatric surgery had more than 35% reduction in the risk of developing colorectal cancer compared with the obese individuals who had no surgery, concording with the previous published result. Now, what about the proposed pathophysiological mechanisms explaining the decreased risk after for colorectal cancer after bariatric surgery? After bariatric surgery, there is decrease in the harmful comorbidity associated with the obesity, increase in the physical activity, and decrease in the pro-inflammatory hormones mentioned before. So we need future studies to clarify the exact risks for colorectal cancer development after bariatric surgery. The conflicting data that are currently available suggests that the progression to cancer is most likely multifactorial. Whoever patient with bariatric surgery should be screened for colorectal cancer more frequently will likely become a more common topic of discussion. Meanwhile, colorectal cancer screening after bariatric surgery in both symptomatic and asymptomatic patients should be considered. Thank you.
Thank you very much, Professor Nabil. Very nice talk. Related with one of the most important cancer we have in our, especially, West population, because the colorectal cancer is not as common in the east of the world, where the upper GI cancer, esophageal cancer, gastric cancer is more frequent. But in the West civilization, colorectal cancer is going to be higher in incidence and prevalence. This is also, one of my questions, because classically, I would say, in the old time, the East people are thinner than the West people, and probably
Yes.
the thinner people are going to be more, tendency to have upper GI cancer, and the West population being more obese or more overweight, going to be a focus on colorectal cancer. I think from the demographic point of view, it's going to be a very interesting point to underline. Do you agree with that?
Yes, I agree with that, and in my conclusion, I spoke about the multifactorial effect. Also, as you mentioned, the East people are more active. The lifestyle are more active than the West, the sedentary life, and I think this activity guard against the colorectal cancer. So I'm totally agree with you about that.
Yeah, I think, in my opinion, the anti-inflammatory effect of this increasing activity, of this losing weight, this anti-inflammatory effect is going to be probably in the near future one of the most important and challenging topic to investigate in this sense. Yes, please, Professor Boras, go ahead.
Yeah, I would just like to add some, opinion about that, because I had the privilege to work in the last 4 years in the Cleveland Clinic, Abu Dhabi, and I'm from Croatia, right? So I have the combination of the East and the West. And what we can see, especially in UAE, I'm not saying that's the situation for the Egypt, but UAE is very, very prone to obesity, very prone to type 2 diabetes, and also they have a increased risk of the colorectal carcinoma. So they have everything that's connected to the West world, although they are not probably, the best example. But UAE is completely like, I would compare it to USA or for the developed Western countries, right? By the numbers, of course.
Yeah, very, 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 very important point, Dr. Boras. You are, putting the arrow in the target, because it's going to be very important. This new evolution of the different societies, merging, obesity and cancer is going to be, in my humble opinion, one of the most important topic in the near future for that. Regarding, because Professor Nabil also commented some of the different mechanisms that can be involved in this situation. He mentioned, the insulin growth factor 1, as also, Professor Kondrasky said in his presentation. And I think this kind of, I would say, hormones or incretins or signal that can be produced by our GI manipulation during the bariatric surgery is going to be important. My question to you now, Professor Nabil, is regarding another mechanism you already mentioned, is the microbiome. The way we change the microbiome with our operations. I mean, do you think it's going to be important in getting some influence on some effect of this protective anti-cancer effect of the bariatric metabolic surgery? What about microbiome?
Actually, the literature are contradictory about it. Gastric bypass produce change in the microbiome of the GIT, and especially after one anastomosis gastric bypass, we found many cases of bacterial overgrowth, and this make some problems to many patients, and this is after gastric bypass will lead as a risk factor for colorectal cancer. However, sometimes this change may be protective. Some gut microbiome increases markedly after bariatric surgery, as shown in the presentation, and this is a supposed factor for colorectal cancer that increase the risk. However, on the other side, some of the literature suppose that this change or alteration in the microbiome would be a protective factor against colorectal cancer. However, the support is, or the evidence is lacking in the other side. I think this needs much more study towards the microbiome and towards the hormonal effect in the near future to alleviate this conflict in the study.
Yeah, I agree with you, Professor Nabil, that we don't have yet enough information regarding very complex topic. You know, we need more information. Any comment, Professor Avitan, Professor Kondransky, regarding this issue, the topic we are talking about? Yes, Professor Avitan, go ahead.
Yes, I don't understand something. If I have understood, some study showed that bariatric surgery increase the risk of colorectal cancer. I can understand with gastric bypass or SADI because you have an anastomosis with the small bowel, but which is the mechanism when you have, for example, gastric sleeve? How to explain the incidence of colorectal cancer with a gastric sleeve?
The literature said that the incidence is much higher with the gastric bypass regarding the proliferation of the unfound proliferation of the rectal hypertrophy of the rectal mucosa after gastric bypass, changing the gastric microbiome. Also, it changes in the gut flora, but we have also something with the sleeve. We encourage the protein intake after bariatric surgery, and they found the pro-inflammatory effect of this high protein diet may have effect on the colorectal cancer risk. This one of the may be one of the causes, but all the literature found that the incidence is higher after bypass, really, not after sleep.
Thank you.
Any other comment? I'd like to ask you a question, because you mentioned, Professor Nabil, you know, very nice study. I'm talking about the Bailey study, where they show a reduction of 34 very outstanding, you know, mega study, you know, many patients showing this effective protection of 34%. Is that right?
Yes, French study.
Okay. Good. So I think, you know, even though there are some controversial numbers and approaches, I think there is no doubt that this colorectal cancer, because I mentioned, it's like the breast cancer, you know, in the woman. They are so frequent, like the prostate cancer in the man and the colorectal cancer in all the population, going to be, from the epidemiological point of view, very difficult to differentiate and to calculate the influence of obesity in this subgroup of patients. But nevertheless, probably in the near future, we will have some more information regarding this topic. We are eager to get these numbers, right? Okay, guys, if there is no other comment, sorry, let's move forward and ask Professor Boras from Croatia to talk us about the positive influence of bariatric surgery on cancer in general. Professor Boras, the podium is yours. It's up to you when you want.
So once again, greetings from Croatia. Good afternoon to everyone. My name is Denko Boras. I'm the head of the bariatric and MIS department here in our today is already been, some things are already been said in the presentations before me, but I'll try to say something about general data about the cancer and obesity, some mechanisms of the cancer promotion by obesity. We'll do some review of the literature, although already some studies have been shown before, and then talk a little bit about the controversies regarding colorectal carcinoma and obesity. So, obesity pandemic, we all know, expands on a worldwide basis, and this number of 2 billion people that will be affected by 2025 is enormous. 13 cancers or 13 malignancies have been directly connected with obesity, and it's estimated that 40% of the cancers are diagnosed directly connected with the obesity. That's the big problem, but the biggest problem are the numbers of the cancer deaths. And if we see the data only for the US, we can see that yearly 100,000 patients, 20% women and 14 men, will die from the cancer related to obesity in US. So these are the variety of the cancers that can happen and that are associated with obesity, and probably the highest numbers are with the breast, postmenopausal, and these hormone-related cancers like endometrial uterus and ovaries. As we can see in this slide, most common type with the male will be colorectal and renal carcinoma, pancreatic and esophageal. So there are big differences between the hormone-related carcinomas with women and carcinomas with the men. So obesity promotes and accelerates actually cancer development and growth by multiple mechanisms, like we already talked, and we don't know enough about those mechanisms. We know I think that we're just beginning to learn what's happening, really. So adipose tissue and adipocytes are mainly the reason why all of this happened. Expanding this adipose tissue contributes to increase circulating adipokines, like leptin, retinol binding protein 4 resistant, visfatin. And not only that, of course, a metabolic syndrome and type 2 diabetes with insulin and IGF factor are also contributing to carcinogenesis. And the problem is also these inflammatory cells, and these dying adipocytes that we have will harbor these crown-like structures here, and they will also be surrounded by the inflammatory cells like IL-1, IL-6, IL-8, TNF-alpha, and CRP, and all of these mechanisms actually contribute to carcinogenesis. So we can actually say that mechanisms of cancer promotion are complex and could not be easily divided in these subgroups like inflammation, resistance, neoangiogenesis. I think they are rather functioning in synergy towards the carcinogenesis, but they all have something in common. Something common is this dysfunctional adipose tissue that starts to die, and then we have the process of chronic inflammation, of insulin resistance, of neoangiogenesis, and also hormone levels that are changing. So what about the mechanisms of the reduction in cancer incidence? They're opposite. So opposite of the promotion, we have the reduction. Metabolic surgery does all of that. So first of all, it deals with a metabolic syndrome. Then it reduces systemic inflammation and oxidative stress, as well as the influence of the sex steroids and gut hormones. When we look at the literature that we have available, there are not many studies, and like Professor Torres said and Professor Nabil, I think we need to do a much better studies designs in the future. This is the biggest problem. All of this, not all, but most of these studies are retrospective, they're observational, they're from the national-based electronic paper studies. They could not be randomized for theoretical reasons. Groups are not homogeneous enough, and then sometimes control groups are inadequate and you cannot compare quite good. So these studies do not achieve the highest level of evidence, and since the cancer and obesity are very well connected, we would need that in the future. So the first study that I will show you is actually the study. It's a meta-analysis of the national population based study from the vegans, and he included here 8 biggest studies that are there available, and he was trying to see what was happening with the cancer risk and obesity. And actually this study showed that bariatric surgery was associated with a significant reduction in overall cancer incidence and the incidence of the obesity-related cancer. The weakness of this review is that all included studies were large-scale comparative studies from registry-based data, and none were randomized in nature. So one of those studies is a study from Dr. Shower that Professor Nabil already mentioned, and this is one of the best studies from this point. And this study said that comparing the bariatric patients that had surgery and obese patients that did not have surgery, we can see that incidence by any cancer was reduced by 33%, which is a very big number. But like I said in the like a comment on the first presentation about the carcinomas, postmenopausal breast and endometrial were the highest one in reduction because they have the estrogen levels and they are very reduced very quickly. So these are the two. And the other thing is that 80% of patients operated here were women. So this is why the results is like that. But anyway, in conclusion, risk of cancer is reduced definitely, and over 10-year follow-up. So this is not just 1 or 2 or 5 years. This is 10-year follow-up. So any intentional weight loss, especially with the surgery, will reduce the risk of the obesity associated cancer. Next study is also already mentioned. This is the study that will show that gastric bypass was associated with increased risk of colorectal cancer, where they matched exact number of patients that had surgery and patients did not have surgery. Patients that had surgery had decreased risk of hormone-related cancers, like we already concluded from the previous study, and gastric bypass resulted in the largest risk reduction. But also, this is the controversy, the gastric bypass was associated with increased risk of colorectal cancer. But maybe the strongest advocate for the increased risk of colorectal cancer after the surgery is this study from De Roger. And this is a retrospective study that had 90,000 patients included. And but it is retrospective registry-based cohort study. And we see that in obesity surgery cohort, we observed that standardized incidence ratio for colorectal cancer increased with the length of time, especially after 10 years or more. In contrast, the overall standardized incidence ratio in the obese no surgery cohort remains stable with increasing follow-up time. So they concluded that obesity surgery seems to be associated with increased risk of colorectal cancer over time. The study that was also trying to show what's going on with the colorectal cancer and try to connect it with the bariatric surgery was this study from Italian Society of Obesity Surgery. It's a study from 2020, and they had data for 20,000 patients, and they divided in groups, and they tried to show is there any difference between the procedure, between the sleeve gastrectomy and gastric bypass. And overall conclusion was there's very low colorectal cancer incidence after bariatric surgery at 10 years. So only 0.10%, and no difference between procedures was seen in this study. So also something open for debate, and it's contradictory to the studies that I showed before. Overall incidence was higher for males in both groups, and the right column was the place that cancer showed that it was most affected, right? Another study from the French from France was this retrospective population-based study with over 1 million patients that were free of colorectal cancer at the baseline when they started the study. And they concluded that the results of this cohort study suggested that following bariatric surgery, patients with obesity share the same risk of colorectal cancer as the general population. Whereas patients with obesity who do not go with the bariatric surgery, who have not done bariatric surgery, the risk is 34% above of the general population, which is almost the same like Dr. Shower's 33% when compared to the general population. So in conclusion, I think that we all know that obesity pandemic will continue to rise and will have a huge impact on the cancer incidence and the cancer-related death. Mechanism of promoting cancer by obesity are multifactorial, as well as mechanism of protection after bariatric surgery. Gastric bypass has the highest influence on risk reduction of developing cancer. Some cancer types cannot be influenced by bariatric surgery. This, for example, thyroid cancer. It doesn't change, not positively or negatively. Reduction in cancer risk is highest in hormone-related women cancers. We see that in all the literature, like postmenopausal breast and ovarian. Debate, controversies, or contradictory results regarding the influence of the bariatric surgery or on colorectal cancer are still open. And of course, we need more better design studies to reach higher level of evidence to see what's really going on with this connection between obesity and cancer. Thank you.
Thank you very much, Professor Boras. It's nice presentation. I think, you really summarized, all the comments we are being doing during this meeting. Again, to reinforce the idea, to point out one of your conclusions, taking out from the field shower study regarding the lowering the incidence of postmenopausal breast cancer and for endometrium. These two cancers, for me, are very, very important, regarding
Yes.
to pointing out, to highlight, the situation we are talking about. Because I'm coming on that because it's very important, very, very remarkable.
Yeah, I think we can take the parallel with a solution of the metabolic syndrome. So we have patients that have bariatric surgery and sorry, they don't lose weight, but still the diabetes improve, everything improves. This is the same. Only this is connected with the estrogen levels or sex hormone levels, right? So this is one of the things that in future we can treat our population, right, with the ladies population with the bariatric surgery, and we can probably reduce the risk of their developing of the postmenopausal breast and all gynecological tumors in base.
Yeah, I agree. You to reinforce the idea of this parallel approach of the metabolic effect of the GI manipulation, globally talking, and the effect on this protection of the cancer reduction. The cancer reduction mechanism are very, very well related with the metabolic effect of our bariatric procedure. I think it's going to be very relevant, very, very important piece of information, Professor Boras. Any other comment on the Professor Boras talk? Professor Nabil, Professor Vitan? Yes, go ahead, Professor Nabil, go ahead.
Yes, good presentation, Dr. Boras, but now we have in the bariatric surgery, we have common issues about the esophageal cancers. We have a problem with the reflux in the sleeve. So Dr. Abitan proposed the nascent sleeve to solve the situation. Also, the biliary reflux after the one anastomosis bypass or SASI. What about the role of the bariatric surgery in increasing or decreasing the incidence of esophageal carcinoma?
Well, I'm sure that bariatric surgery has influence on that, and we know that. But I think that we need to see what is the baseline. So we need to know the status before we do the surgery. So we cannot offer the sleeve gastrectomy to someone who has already reflux disease, right? So I don't think everyone is doing that properly, especially in this area around Croatia. So because the sleeve is the procedure that everyone will do because this is the easiest. So we don't know the baseline. We don't have upper GI endoscopies before the surgery, so we don't know what's really happening. What about the silent Barrett esophagus? You cannot just ask the patients, do they have an issue with the reflux, and not do the endoscopy before the surgery. So I'm sure that we don't have a proper algorithm, in evaluation of that. But I'm sure that, of course, you can worsen person's GERD disease and developing of the esophageal cancer with the bariatrics, of course.
Okay, thank you. Any other comment?
And I tried to find any information about esophageal cancer after bariatric surgery, but I didn't find anything. Only like cases, and that's all. It's interesting term for me, and I think it's we have some information, I think, in the near, but now I didn't find any literature about it. Yeah, thank you. It's very interesting presentation for me.
Dr. Avitan, any comment?
Very good presentation. I am confused because does bariatric surgery increase the risk or decrease the risk? But I am sure that the reflex increase the risk of esophagus cancer. I am sure that all the anastomosis with the bowel between the gastric, the stomach, and the bowel increase the risk of the macrobroth, so cancer colorectal. But I cannot. I am confused. Does bariatric surgery increase or decrease? I am confused. Very confused.
Yeah, there is no doubt that there is some absence of information about many factors involved in this topic. But there is no doubt that for sure those kind of cancer, at least the most prevalent cancer like colorectal, breast, and prostate, and other cancer are going to be. But interestingly, there are some investigation also studying lung cancer. Lung cancer related with smoking, but also with obesity. There is a theoretical relationship between the gut and the lung, and the mediators, between the two organs. And also, I think going to be very interesting to follow the new studies and the new basic and translational investigation between these two topics. Any other comment, guys? Any other before giving the final remarks of this outstanding meeting, this outstanding seminar? Any comment? Last word for all of you guys. Let's start with Professor Kondrasky. Last words, Yuri.
I don't know. It's first experience for me, and I never spoke with bariatric surgery before because we always talk. It's very interesting for me, and I think we go further. And thank you everyone, because it's very useful for me, and I think we will meet again, and I have more powerful cases for you. Of course, thank you everybody.
Thank you very much, Professor Kondrasky, for your participation in this webinar. Professor Nabil, last words.
Yes, I'm really appreciated to be with you today, and I think it's now clear that some cancers risk is decreased after bariatric surgery, like endometrial carcinoma, pancreatic tumors, and pancreatic cancers and breast. And some cancers doesn't change the risk, like thyroid, as Dr. Porras mentioned. And there is still unclear evidence about the esophageal and the colorectal cancer. That's to me to alleviate the confusion with Dr. Apitan.
Okay, thank you, Professor Nabil. Thank you very much for your kind participation in this webinar. Professor Borras, last words for you.
Thank you all for the great presentations, and for the great moderation, Professor Torres. I think these kind of webinars are very important for us to see what are the problems and the things that we don't know yet about the consequences of the bariatric surgery or not doing the bariatric surgery, especially in the countries like mine, where we don't do a lot and we are starting, and we can just compare to a bigger centers and learn from that. So this is, I think, the learning is the main point of all of this.
Good, thank you very much. Professor Apitan from Morocco, last word from you, sir.
Thank you so much for this invitation, this webinar. I have learned a lot today. I have learned a lot. Thank you so much. Thank you so much.
Okay, thank you very much, Richard. Let me do the final remarks of this webinar. As in any training, in any learning course, we probably answer some question, but sometimes it's going to be important to get more questions than answer. It's going to be the learning process. If you talk about that, you solve some doubts, but you generate some more doubts. This is the learning process. Teaching and learning as always the same. I think this seminar has been a very good example for that. This is the main reason I'd like to warm up, saying that bariatric and metabolic surgery is one of the most important topics at present time in any scientific forum. And all of us agree, at least in this message. When we are manipulating our GI tract, performing sleeve, gastric bypass, SADIS, BPD, any or endoscopic procedure, we are inducing some changes that not only can be followed by weight loss. Weight loss is just one part, probably important, but there are some other mechanisms involved in the consequences of our GI manipulation. Regarding the carcinogenesis, all the speakers, all the our colleagues talking today about some factor, insulin growth factor 1, all other anti-inflammatory effects regarding the bile acid, the interrelation with all the receptor we are involved there. There are some other mechanisms, even the hormones, the classical incretin hormones, and the proliferant effect of some mediator like insulin growth factor. So bariatric metabolic surgery are inducing changes in our organism that much far away than just losing weight. I think it's going to be a very important point to summarize. And another important point I think I am taking as a conclusion of today's webinar is related with the future perspective of this topic. There is probably in the near future no meeting, no congress, no educational forum where this relationship between cancer and obesity and the effect of bariatric and metabolic surgery over these two topics will be absent. Many for not saying all this meeting will include this topic in their program, in their armamentarium, I would say. This is the reason I'd like to thank again Series-6th Medical Company, for allowing us to be together today to share this information and to learn so many things at the same time, to pointing out some other question non-answered question, then probably will be the topic for near meeting. So I think it's time now to give the word again to Tarek from ASR Medical Department for closing the webinar if they consider it going to be convenient. Oh, Tarek, can you hear me? I don't know if he can hear us. I don't know. Let me check if he's here. Well, I can see SCA Medical, but I don't see them. Let me ask again. Tarek, are you there? Okay, if not, I would say to say goodbye and again. 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 So much for this nice webinar. Congratulations. I hope to see you very soon in person, face to face, after this terrible pandemic pass away. Okay. Take care. Bye-bye, sir.
Thank you. Bye.
Bye-bye.
Bye-bye.
Bye.
Muchas gracias, Dr. Torres.
Okay. I think everything has been okay. I think the meeting has been very nice. Do you agree, Lucas?
Yeah,
Good.
actually, this is really good. And I'm listening to viewers discussing
Okay.